Hey everybody, welcome back to another VMR. This is, I think, our second rapid response VMR. I'm Andrew Sanchez, part of the CP Solvers team, and it's good to be back and to see everybody this lovely morning. Hope everyone's doing well today. And Rabih's here and Ravi's here. I don't know what's in store for us, Rabih, but let's see.
Yeah, it's gonna honestly the hardest thing with rapid response VMR is the fact that we're jumping into so much acuity. But with you here, I'm not so worried about that problem. I'm a little bit worried about I continue to struggle with a Rabih versus Ravi. And so if I accidentally interrupt you, Ravi, please forgive me, but we'll pass the mic to you to tell us what you have in store today.
All right, so we're streaming live from the sim lab. I'm in the sim lab today, so I thought it'd be a great opportunity to do a rapid response sim straight from the sim lab. So I'm gonna start this off. You arrive because you're called to see a patient. You absolutely don't know anything
Rabih,
about this patient.
Can I jump in real quick? I
Sure.
think because you're talking into the Zoom screen with your beautiful puppy picture, the sim screen will probably not be featured as the main video on YouTube. So I don't know if you have the ability to talk into to unmute.
I just pinned the screen for Rabih.
Nice.
Hopefully that works. I think that works.
Yeah, I think that's actually a much better solution than I had in mind, but I think he's just about to unmute the screen too.
I see.
All right.
Oh, there you go.
Can you hear me now?
Yeah, this is perfect now. I think that'll be, yeah.
All right. All right. What I'll do then is reduce the other screen. Okay, here we go. So you arrive, you're called to see this patient. You absolutely don't know anything about this patient. The patient was brought back from hemodialysis. While she was in hemodialysis, she was crying because of chest pain since early morning. The hemodialysis session is cut short. She's brought back to the room, and the nurse goes to check on the patient, and she is altered, unresponsive, and not responding to any pain or stimuli. I'll stop right there.
Oh wow! So we're gonna turn right in the deep end, Rabih. So I'm assuming the vitals on the monitor here are accurate, Rabih. So if I'm interpreting this correctly, the heart rate is in the 80s. The SpO2 is in the 80s. Oh, okay, and low, and her blood pressure is normal here. So she's walking into the room hypoxemic here. So we want to escalate her oxygen to try and get it so that she's saturating. Okay, so when we walk in the room here, we want to put her on like a non-rebreather mask just to try and stabilize her acutely. But then question number two, when I'm walking into a room where a patient's super altered and hypoxemic, is does this patient need to be intubated? Is something I'm always thinking about, like right off the bat. And what I've been taught is kind of, when you see it. Things to look for me that are not hard cutoffs are like gurgling, like can this patient protect their airway regarding secretions? Are they gonna have a massive aspiration event if we don't do anything? And then just like level of unresponsiveness. So it sounds like the patient's pretty unresponsive right now. So those are two things that first come to mind. And then we can tackle this from chest pain, hypoxemia, which are probably going to be related. But then really quick regarding altered mental status, just to quickly do a checklist on that front. I like the mnemonic scan for altered mental status. It covers all the pertinent things you don't want to miss acutely. So S is for sugar. So we would get a finger stick on this patient just to make sure that we're not missing any hypoglycemia. C is a CT head, which is going to be kind of later down the list for us in a patient like this. A is ABG, so we would definitely want to get in someone who's unresponsive and who's hypoxemic, at least a VBG. We say ABG because it fits in the scan mnemonic, but really what we're looking for in a blood gas is just ruling out retention. If this patient was very, very tachypnic and then they suddenly stopped being tachypnic and started retaining CO2, they could be obtunded from that. So we would get a VBG to make sure they're not acidemic and acutely hypercapnic. And then N is narcotics. We would just quickly ask the team, has this patient gotten any sort of like opioid from the chest pain earlier in the day? That could be very possible, actually, that someone gave this patient a bunch of like IV Dilaudid since it sounds like they're on dialysis. And at that point, we could just give empiric naloxone to see if they get better to try and stave off an intubation. So those are my initial like off the bat things I would want to get. So it would be finger stick, VBG. I would ask about the narcotics, and then I would definitely go down the chest pain pathway and get an EKG. Maybe I'll just pass it off to Rabih, maybe for like the chest pain evaluation, which is going to be kind of like we're doing that at the same time.
Yeah, no, I completely agree with you. I think you're thinking thorax and brain at the same time. And I think that I have nothing to add to your reflection, Andrew. I think it's absolutely superb. And I think the key question will be, as you execute the empiric chest pain workup of point of care ultrasound, EKG, and basic labs, I think the key thing not to fall into the trap here is to label the problem prematurely as somnolence without focality. And I think the key thing to try to do is to try to determine if there's focality. And the reason that would change things is it would reduce the time to CT scan. And so if you walk into this room, I think it's very easy to get sucked into the severity of this illness. But I think a quick neurological assessment to determine if there's asymmetry or not, from pupils to face to hands, will really, really up the ante and will help you. I love the scan mnemonic, and I think that all the other things except the C happen quickly, and you might move much faster to the C if you find focality. So I think our problems are altered mental status without known focality yet to be determined, chest pain and hypoxemia. And I'm really curious to see how those will elegantly come together. But I agree with how you frame this. This is all about trying to stave off intubation. In a syndrome that is taken off so quickly, the probability of intubation in this patient is through the roof unless there's glucose or Narcan involved. Because if they're this obtunded this quickly, and we can't find anything to immediately reverse, what's their status going to be in the next 5 or 10 minutes? Only going to be worse. So I think early intubation in these patients, unless you have a rapidly reversible causes of a wise idea. All right, Ravi, tell us more.
Okay, great. So some of the requests that Andrew had, finger stick is 180. Patient was on morphine for pain, given Narcan without any reversal of their condition. And a little history is obtained. So this is a 57-year-old female with a past medical history of end-stage renal disease on hemodialysis, hypertension, and had a right femur fracture and ORIF several days ago, which was uneventful. Patient currently is on antihypertensive meds, pain meds, and heparin for DVT prophylaxis. And the vital signs, as you can see up on the screen, so temperature 37.6, heart rate 90, 85 to 90, and respiratory rate around 24. The pulse ox is 89 and is partially fixed with a non-rebreather, so would go up to about 95. And then, would you like the exam? Yes, Andrew? Okay.
Yeah, that'd be.
All right, let's go with the exam. So when you look at the patient is looking to the right side and the eyes are also fixed to the right side. On the left side, because the patient's unresponsive, the tone, patient's not flexing to any painful stimuli when you do sternal rub or rubber or some painful stimuli around the eyes, but the patient's tone is asymmetrical. The tone is diminished on the left side, and the leg is diminished on the left side. Otherwise, rest of the exam is unremarkable. The other thing I like to point out, the patient's gag, unable to protect the airway.
Okay, that's really helpful. So I think the last information we were just given there, or rather the last one is concerning for impending intubation. So I think getting ready to call anesthesia for a patient like this would be on your mind. Immediately prior to that, the tone, Ravi, I think your mind was read. I think probably getting stroke here, just to have a better exam would be helpful. That's what I would do in real life. I really don't feel confident enough to call like focality on my own, but I would probably call like a stroke code at that point just to get their evaluation before this patient gets intubated. Because basically I was concerned about focality, like if there really is asymmetric tone, I'd be concerned about focality. But there is a lot of other stuff going on. Like, again, they are hypoxemic. I still would want to go down the cardiopulmonary like pathway to like making sure we get the EKG ASAP, getting the troponin drawn, getting a chest x-ray too to see what we see there, because that could be like muddying the picture as well. Other than that, just in terms of like other exam things I'm looking for acute hypoxemia, there's a really good approach by a hospitalist in Boston. I can't remember their name. I wish I could. I'll have to send it to you all. But their approach to acute hypoxemia is really elegant. It's kind of like you walk in the room, what do you see and hear first? So do you hear any stridor suggestive of upper airway pathology, which it sounds like we're not hearing here. We're just hearing like gurgling just because of their poor mental status. Are they hypoventilating? That would be because of things like narcotics or chest wall deformity or obesity hypoventilation. It doesn't look like they're hypoventilating here. You can actually see the chest rise. And then once you do those observations walking in the room, then you actually put your stethoscope on the chest to see what you hear and see if they're kind of like auscultation positive. So like, do you hear diffuse crackles? That could be suggestive of edema, blood, pus. And do you hear decreased air movements, or do you hear any wheeze suggestive of COPD, asthma? And then like the separate category is kind of like auscultation negative stuff, which is like PE is kind of the idea. Like you don't hear anything in the chest x-ray looks good. So imaging negative, auscultation negative. You think PE in a situation of acute hypoxemia. But in real life, the reality is a lot of these patients have like COPD, heart failure at baseline. So you have to think about like kind of what their trajectory was for that category, that you could hear some crackles, you could hear some wheeze, and they were like doing better with the therapies you were giving them. But then maybe one day they just have a sudden turnaround. In that situation, they're technically not auscultation or imaging negative, but it was that turnaround that makes you think maybe this is a PE. So that's one way we could think about this patient's hypoxemia too. Given the chest pain, I think I am very curious about the EKG. I want to make sure we're not missing ACS, and then certainly PE too after the patient stabilized.
Yeah, Andrew, I completely agree with your assessment. I think that the key thing is to stabilize this patient because you need the diagnostics in this case. And I think that getting control of the airway is so crucial. And I doubt you can move this patient without an intubation, honestly, based on what we've heard. Though, you know, these assessments are different in real life than they're often portrayed. And I completely agree with your assessment. I'm just going to try to crystallize it and try to like summarize it. Essentially, we're worried about the brain and we're worried about the thorax. And I think we can't do anything about the brain in terms of treatment without knowing what's going on. We really can't. However, we can do a lot for the thorax empirically. We can fix the oxygen with oxygen, and that is empirically done. And we can protect the airway with intubation without knowing what's going on. So that's why I think the diagnostic focus is what's going on in the brain, because we can't do anything about that until we know what's going on. So of the numbers that you see here that are blinking, the oxygen we got, intubation probably, airway control. The blood pressure is an interesting question. I saw some comments in the chat about trying to control that. I think it's a real tension, because you can use that blood pressure and that SAT, combine them and say this person has flash pulmonary edema. And so that would urge you to try to lower the blood pressure. However, I would make the argument to avoid doing that in this specific circumstance for two reasons. The first is that if you're going to intubate somebody and you're going to sedate them, and the risk of hypotension from the intubation itself is one reason. The other reason is if you're invoking a focal neurological syndrome, the perfusion pressure of the brain may be important to you. And that hypertension may be really important to perfuse the brain in the setting of a hemorrhage or even an ischemic stroke. So you may not want that blood pressure lower. So if you weren't going to intubate the patient, you probably would have a much harder decision. But since the only goal of blood pressure control for flash pulmonary edema is oxygenation, and you're going to the full depths, you have to go to the full depths of oxygenation because of the airway, I might let the blood pressure ride here until the CT scan. So summary, the brain, we can't do anything about. We can do many things about the thorax. So let's do those things empirically and focus on what the brain might reveal. And the key question for us, Andrew, is putting ourselves in real life. So hypothetically, you intubate the patient, you stabilize temporarily the thoracic issues. What might you think of doing in the CT scanner in terms of, you know, you'll probably only get one trip, honestly. What would you get down there?
Yeah, I think just the standard stroke pathway, like the non-con head CT, just to rule out like a large intracranial hemorrhage, and just working with our neuro colleagues at that point. That would only show like a large hypodensity in terms of like a thrombotic stroke, but it would show like large brain bleed too. So probably that's a good starting step.
I know, I completely agree with you. I think that's probably the best way to analyze the brain. If Rabih hands us a non-ischemic EKG, how might that influence what you do down in the CT scanner?
Here we go. Well, so while we're down there, if we're still at that point confused as to what's going on, then we could consider getting like a CTPE of the chest while we're down there too. Yeah, I'm hopeful at that point we would have like a chest X-ray. Maybe if it did show like a ton of pulmonary edema, we would have our answer right there. but we can certainly, this patient's already on dialysis, so there's no like risk of, giving this patient contrast and just scanning while we're down there too.
Absolutely love it. You're like hitting home run after home run after home run. I'm trying to find your growth margin. So I'll ask you the hardest question I can think of, which is on the lab. We're going to get labs, and we often see markers of critical illness, like a little low pH or high K or whatnot. What labs are you interested in from a diagnostic perspective? Do you think there's anything that might be productive in the labs in a patient who, again, I'll sort of summarize the context for everybody: orthosurgery, heparin, as the only real relevant context. Thoughts on how the labs might help?
In a patient who's very sick like this, a lot of findings could be like non-specific, like a troponin we will send in this patient, but it being elevated is not going to tell us if that's ACS or not. I'm a big believer in trending EKGs for something like that. So we're going to put our stock in serial EKGs for this patient. But send troponins with the understanding they're probably going to rise just in the setting of the patient's critical illness and like big hypoxemia. The BMP, yeah, like you're saying too, you can spike things like creatinine increases along with this. LFTs will go up as well. BNP, you could compare it to baseline, but it's really more of it's really more of a clinical picture that we need for this patient. We really need like all these data points together, I think, to kind of make a decision on what's going on and what to do. The VBG up front, that would be very helpful to prove to ourselves that they were hypercapnic. Again, we don't need that necessarily, I guess, to like intubate this patient. Like we know it when we see it. It sounds like they're not protecting their airway. But if that's a very rapid thing we can get. So we could get a VBG just to like demonstrate the hypercapnia. Maybe if they're more borderline, we would say, okay, like let's do this. But this patient sounds like they're pretty obtunded, so we would just go for the intubation kind of regardless. But if we do get it, it probably is going to show a low pH and a high CO2.
Yeah, 100%. I love the teaching that you're giving us here, which is that there's so many non-specific findings that have much higher specificity outside critical illness to trope the VBG. And I got to tell you, this is having been in this situation before, there's something unique that you have to consider here, which is the possibility that the chest pain and the brain stuff are both thrombotic issues. So you already thought about PE, you already thought about stroke. And so the question is, how can somebody with orthopedic surgery get such thrombi? And the answer often is that it's just the surgery itself. But the moment you hear post-orthopedic surgery, you really have to think about something super esoteric, which is fat embolism. And I know that crossed your mind, but something more practical, which is that this patient has heparin-induced thrombocytopenia or HIT. So for me, the thing that I'm really, really going to study is the platelet count, because I can't tell you the number of times that a platelet count of 90 or 100 doesn't catch my attention in a critically ill patient. But if their platelet count was 300 yesterday, gosh, that matters a lot. So I've learned to deliberately program my mind in this situation to actually study the platelet trend, no matter what it is. Even if it's 160 today, and if it was 400 yesterday, that is really, really concerning. So for me, the most diagnostically important lab that actually is worth studying with extensive detail, no matter what it is the platelet count. Thoughts on that?
That terrifies me if that's what's going on. I didn't catch what you were going for with like the ortho connection. That makes complete sense. I'm excited to see what's coming next from Rabih.
All right, Rabih, tell us more.
Excellent discussion. Is just impeccable teaching, both running rapid stabilization thoughts to rapidly stabilize a patient, simultaneously also analyzing what could be going on. So a gold mine of teaching there from both of you there. So continuing on with labs, so troponins are actually normal. Y count 10.66, hemoglobin 7. Platelet trend is flat, currently 254. Chemistries normal except for lactate being 6, bicarb 25, and there's an anti-gap of 16. And the rest of the labs are normal. And BNP is close to about 700-800. And EKG does not show any signal of ischemia or ischemic injury. And I'll stop there.
What do you think, Andrew?
I was just putting everything in the chat here to I forget. So there's a significant anemia, a hemoglobin of 7. You know, the patient has ESRD that may very well be near their baseline. So we would have to look at that. You know, the patient's sick in terms of the lactate of 6, the anion GA. The bicarb surprisingly isn't low with that. The EKG, it sounds like it's reassuring for this is not ACS. By now, I'm sure we would have seen something since the chest pain had started like hours before, it sounds like. So I guess we can kind of like put ACS lower on the differential. So yeah, this is curious. I feel like I still want the chest X-ray just to see if there's a ton of pulmonary edema that we're missing, but it sounds like there's no ACS driving like flash pulmonary edema. Hypertension driving flash pulmonary edema has been brought up. So we'll just need the chest X-ray to kind of interrogate that a little bit further. If that's negative, then I think the CTPE is what we're dealing with, kind of like the auscultation negative, imaging negative workup. So making sure we don't miss the PE. And if that's negative in terms of just like this patient being so acutely altered, then yeah, I guess this could all be in brain, just a catastrophic like intracranial process. So maybe this is starting to point more in the direction of CNS driving just breathing issues in this patient. So yeah, in terms of next steps, I think chest X-ray, CT head, and let's get the patient to the ICU.
I love it, Andrew. I have absolutely nothing to add. Rabih, tell us more, please.
Okay. Brilliant, Andrew. You scored a hat trick and knocked it out of the ballpark. So very good. So the chest X-ray on the patient is on the way to MICU, going to have their brain scan, gets an X-ray because of intubation, and the X-ray shows clear lung fields and widened mediastinum. I'll stop there.
Oh, wow. Okay. So I think we have something that could tie everything together. So yeah, Ricardo in the chat, why did mediastinum and what more? So yeah, that makes me think of aortic dissection, which, you know, if this patient had acute onset chest pain in the morning, you know, that adds up. It's a very acute condition. And that could like affect your CNS as well in terms of like the dissection, like moving upward in the aorta and affecting the vessels going to the brain. So that could explain like the focality that we're seeing in the brain exam, and the clear lungs. Like it's not really driving. It's not causing ACS at this time, and it's not causing any edema. So it sounds like the chest pain is from maybe dissection, and at the same time, it's causing these CNS findings that we were talking about. So I've never treated this before. I've actually never seen this before. So we'd probably want to talk to CT surgery to get their thoughts and actually like get the CT scan of the chest with contrast to like actually interrogate the aorta more, so we know exactly what we're dealing with, like how far it's dissecting down. And then we would have to do aggressive blood pressure control to make sure that that doesn't propagate any further. And I don't recall off the top of my head the blood pressure goals for the dissections, and the management differs a little bit from proximal to distal, I remember from med school. But basically at this point I would be talking to CT surgery and getting that preliminary workup, knowing that they're gonna want that. Rabih, what else do we need?
Yeah, you know, I think it just goes to show you how powerful this case is and what you can try to have a no slack in your workup line. And I would make the argument that the widened mediastinum here is profoundly helpful. But I would say that whenever you have a patient who has chest pain, who is critically ill, you need an answer. And if the EKG does not give you that answer in chest pain, you need a CT scan. Because every other sinister cause of chest pain is caught on a CT scan with contrast: PE, aortic dissection, esophageal rupture, large pericardial effusion. So I think the profound learning here is to study mediastinal widening, but I don't think you need to rely on that because it's absent in up to 30% of patients, the aortic dissection. So I completely agree with your line of thinking and would just also try to emphasize the point that even absent the X-ray, if you just think about chest pain in a simplistic manner, which is the patient sick enough that I need an answer today? The answer here is yes. And if the EKG has not given me the answer right now and they're really, really sick, how else do I get to the bottom of it? So I think this patient, even absent the X-ray, probably needs a CT scan contrast. And I completely agree with your reasoning that now an aortic dissection with neurological compromise becomes the leading diagnosis, with the caveat that unfortunately mediastinal widening in real life can often be positioning and rotation issues. So that's how one we could be fooled. But I think it doesn't matter. It doesn't change our management. I think a next step is CT from brain to diaphragm. All right, Ravi, tell us more.
Okay, I'm going to lean on Maddie a second to display the CT scan of the chest. The CT angiobrain, though, shows a severe acute ischemia through the right MCA distribution. Hence, the patient gaze to the right side, to the area that's infarcted. And then we'll have the CT scan of the chest also on.
Thanks, Maddie.
Okay, so the CT scan actually found a dissecting thoracic aortic aneurysm, which is partially imaged here, is about 4.6 centimeters, and it extends into the right common carotid artery, shows near complete occlusion proximal to the bifurcation with diminished distal runoff into the remainder of the right internal carotid distribution. So yeah, this was quite a significant finding, and something I don't think was anticipated when we actually went through the case, and it is actually one of the simulation cases I run here. So the one thought I had, which Andrew had thought about, was definitely PE. Heparin is not foolproof. Heparin does have, it dissipates pretty quickly, so there's downsides or downturns in its concentration, and there can be prothrombotic effects or episodes where patient can develop DVTs, and a stroke emanating from that could be a paradoxical embolism. That's what I was thinking when going through this case, but I've never seen this before, like Andrew mentioned. So very, very astonishing and mind-boggling case, but I think it's something that we'll probably think about if faced with this kind of scenario. Back to you, Andrew.
Yeah, just very that's a very tough case for the patient. That'll be, a very large stroke and cause a lot of devastation. So that's very sad to hear that happened to them. I don't know if TPA is something we would give in a scenario like this. That's again something we would have to ask neuro, that they'd be here by now, to try and save as much brain as we can. But with the etiology being a dissection, maybe going to like CT surgery like rather quickly, I imagine that's probably off the table. But I'm not sure. Rabih, do you know if that's something that we could do here?
Yeah, I think you
So-
should. Yeah. Oh, Ravi, go ahead. Sorry.
Oh, go ahead. So not in this case because it was an occlusive stroke. So just walking back to what Andrew had mentioned, blood pressure goal would be very important, and also thinking about what Rabih had mentioned, that if this was a ischemic stroke, you need that permissive hypertension. But in this case, you need the blood pressure target about 100 to 120 millimeters of mercury, and the heart rate less than 60. So you want to at least start an IV beta blocker, something like esmolol or labetalol, followed by a vasodilator. So you don't want any reflex tachycardia. But in the case for this patient, actually, the outcome was pretty good. The patient was seen by CT surgery. They fixed the dissection immediately via graft placement, and there was minimal surgical complications. Hospital stay was relatively benign post-operatively, and the patient was discharged home about a month later and is living at home and fully functional, back to normal.
That's
Back to you,
great.
Rabih.
That's fantastic. Yeah, Rabih, what are your thoughts?
Well, I think there's so much fascinating learning here, and what a thankfully rare but important journey. I'm curious, what learning would you emphasize, Andrew?
This is a very complex case because there was neurologic compromise, pulmonary compromise, and then with the chest pain, we didn't really explicitly go down the chest pain pathway. Perhaps we could have done that to just like add to our list of items on the differential dissection. With the 4+2+2, it would have been on there if we actually talked about it explicitly. I was thinking with the hypoxemia that this would be more like ACS. That's kind of what I was expecting from the beginning, just like acute hypoxemia, chest pain. I was thinking this patient's gonna have like crackles, have a positive chest x-ray, but that wasn't the case. And at that point, maybe we could have stepped back and done the 4+2+2 checklist just to make sure we didn't miss other causes of devastating chest pain. But this is so rare. Actually, I'm really glad I got to go to this and do this, because now I feel like down the road, hopefully I won't miss something like this. Yeah, very, very rare. Thanks, Rabih, for presenting this.
Yeah, I echo that, Rabih. This is just awesome. The sim, I mean, I think that in Rabih, we just have such a dedicated and elite educator going above and beyond to like bring these rare but important cases and bring them to life, like literally like with a mannequin and blood pressure and everything. So thank you so much, Rabih. And for me, honestly, Andrew, the highlight was like remembering your first contributions on VMR 3 years ago and seeing how you're effortlessly taking care of this patient and thinking through such complex things in real life and ending with how you could have done better. And I think that's exactly what I strive to do every day, and know that that's sort of the CP Solid mantra, is like push yourself to grow and grow and grow, but celebrate what you've already accomplished, and I think you modeled that so well. And I will just end by emphasizing the 3 things that I will reinforce for myself in this case and study more closely. I think the first of which is the difference between obtundation without focality and obtundation with focality. It rapidly, completely changed the calculus in this patient, and I'm going to incorporate your scan mnemonic in my teaching, because I think it's such a great way of emphasizing the acute thing you need to do: sugar, CT scan, ABG, and narcotics. And then the other reflection is to emphasize that a practical approach to chest pain, agnostic to the diagnosis, really only has 2 questions: is, do I need an answer today based on what I've heard from the patient? Terrifying story. That's the first question. The second question is, does the EKG give me that answer? And if the answer to the first is yes, but the EKG does not give you the answer, there's only one next step: it's the CT scan with contrast. And the final point I'll emphasize is this: if you have a patient who has a thoracic syndrome and a neurological syndrome at the same time, there are many common diagnoses that connect them. However, if you have a patient with a thoracic syndrome and a focal neurological syndrome, it's an aortic dissection until proven otherwise. There's very few things that cause focal neurological issues from the chest. And a PE with paradoxical embolism, which was my leading thought, like Rabih, in retrospect, is much less common than aortic dissection. We have to invoke a lot of things to have PE with paradoxical embolism. So that will be my growth point, is to actually have realized that it's not a PE with paradoxical. That's way less common than aortic dissection. So 3 really, really important teaching points for me to reflect on. Cool, y'all. Rabih, I'll have you have the final word. What stuck with you in this case? And I'll have you sign us out, please.
Oh, just to keep all the options open, like Andrew had mentioned, the 4+2+2 is a valuable tool, and I actually use it in simulation for patients with chest pain. And aortic dissection tends to be less entertained as a possibility, but yeah, this is an eye-opening case. I've never seen this before, so definitely it's going to be on my list of possibilities if I do come across a case like this. But I think the wealth of teaching and the possibilities of learning from this case and the discussion here is just a gold mine of pearls. And I think it's a pleasure to stream this from the sim lab. I think it gives insight to people of how our practice is as far as education of residents and students. So as you can see, Andrew did an exemplary job going through how to stabilize a patient, the workup of a patient, also entertaining all the possible diagnoses and using a great mnemonic. I'm also going to use this scan mnemonic as well. I think it's really helpful. So, yep, I think that ends CPS Rapid Response VMR today. And it's been a pleasure hosting all of you, and hopefully everybody learned something.
Oh, heck yeah, Rabih. Thank you so much. All right, we'll see you all next time.
Bye, everybody. Thanks, Rabih.